Sheila, do you want to do roll call?
Sure. Ms. Bernard? I don't know if you're on mute.
Are we asking for Hadass? I'm
Yep,
sorry.
Ms. Bernard, yep.
Oh, I'm here. Sorry about that. I couldn't hear you. Sorry.
Oh, sorry. Mr. Furman?
Okay.
I'm present and joining from Troy, Michigan.
Oh. Yeah, Ms. Bernard, do you want to state your location?
Oakland County, Ms. Bernard.
Thank you, sorry. Dr. Guadalupe? Dr. Hans?
I'm here in Bloomfield Township, Michigan.
Mr. Landsman? Miss Namie Dyer? Miss Newman? Miss Root?
Good evening, here from Royal Oak.
Miss Summers?
Here from Royal Oak.
Dr. Taub?
Here from Bloomfield Township.
Mr. Torres? And Mr. Lindemere?
Here in Waterford, Michigan.
And I'm hoping I
Okay,
didn't miss any.
the next item on the agenda is public comment.
We do not have any public comment this evening, but I do want to remind people that we have two opportunities. They can type their comment in the chat, or they can use our online form, and then customer services does respond to all of our public comments.
Great, thank you. Okay, we're going to go on the business operations portion of the agenda, and Anya is going to give a financial review.
Good afternoon, everybody. We are going to look at January financials. So you can in advance, I don't know who's doing slides, so I apologize. This is the chart that just looks at the eligibility trend as it relates to our revenue. So you can see that the January revenue is up significantly, or at least I would call it significantly for us from the prior year, and that really is primarily due to the eligibility trend. And we will expect that to continue for the remainder of this fiscal year, that it's at this upward trend and continuing to see an increase. Next slide, please. So this is the actual eligibility trend. This one gives you a little better understanding of where those eligibles are coming from. Our biggest increase right now is really Healthy Michigan. I believe I saw it today at about 80,000, which is higher than I've ever seen it. And I do believe I heard that they're opening that back up recently. So again, because we're paid on eligibles, not on the number served, that's good news for us because it means an increase to revenue for us for at least a year. So moving on to the next slide. So this one is the assets. And so this is assets as it relates to the end of last fiscal year, which is unaudited at this point. Compared to January of the current fiscal year. So you can see our cash and investments is up, our receivables are down, other assets are relatively flat, and then capital assets continue to go down with depreciation. Moving on to the next slide. Liabilities, you can see liabilities are up slightly. That's usually just a timing issue. Receivables is down, other assets, again, roughly flat, and then capital assets slightly down. So our net position is up slightly from the end of the fiscal year and fiscal year 20. Again, we're only a couple months out from that, so you wouldn't expect to see material changes other than to see that, yes, we are going in the right direction. So that's a good thing. Total liabilities are down. So our net position, the result of that is our net position being up. So this is our revenue comparison. So this compares revenue this fiscal year to date versus last fiscal year to date. So it's the same time period in both fiscal years. So you can see how much our Medicaid revenue is up. So that's about $20 million. So that's a pretty big increase year to date for Medicaid revenue. General fund is roughly flat. The only slight difference would be that grant we had for PPE last year. County funds remains flat. And then all other is just slightly lower than it was this time last year. So this slide compares the same time periods just for expenses. So you can see administration being down. Again, that's related to that shift in how we categorize administration. Provider network being down as well. I talked about that. I've talked about the last couple of months is that there's a bit of a delay with how we're paying providers right now. So it takes a few months to catch up. So we should see that picking up within the next few months. Grants are down just slightly, primarily due to some of the grants we had expiring. And then all other revenue is almost exactly flat. I'm sorry, expenses.
Jonathan has a question, Anya.
Okay. Jonathan, do you want to go back one slide?
Good afternoon. Hopefully, yeah, I'm back on expense.
Okay.
Okay. So yeah, yes, you're right. The things that these are lagging indicators with expense, but I know that you also have visibility into the day-to-day right now.
Mm-hmm.
So we're about 6 months into the fiscal year. How are we looking from an expense perspective compared to last year, especially since we have an extra $20 million of revenue?
So expenses are roughly where we expect them to be at this point in the year. Remember, there is some level of seasonality we do see within our network. So these first 3 to 6 months tend to be a little bit lower than the latter months. Just weather, I mean, COVID obviously has had an impact on that, but we do tend to see a bit of seasonality within our system. So I would actually expect it to be a little lower this time of year. And then again, that compiled on the fact of how we're reimbursing people right now. Is multiplying that effect. So it'll catch up. We're still underspending currently through March from what I've seen thus far. And again, revenue is up compared to what we budgeted even as well. So that will be something that goes into budget amendment 2, which I will likely try to have done for next month. We wanted to wait to hear kind of how the governor was going to in the legislature we're going to play out in this $2 situation. So we will be adjusting that hopefully next month. But year to date, we're doing well. And I have to always caveat that with remember that we did spend a lot of our reserves in 18 and 19. So now is the time for us to be putting that stuff back in there so that should this happen again, we do have the reserves to cover expenses like we did before.
Okay. Thank you. And with the budget amendment, are you going to take that into consideration as well and try to bank some of this 20 mil?
Yeah, so we will take that into account. When we provide medically necessary services at all times, we really don't, it doesn't fluctuate all that much unless something material changes. So the goal would really be to put any excess outside of any long-term investments like the direct care wage pilot, for example. So some of those things we've already planned to do that were already kind of built into the budget. But yes, any excess revenue, the goal would be to put it away for any future years where we do have deficits that we would like to cover so that we don't have to make any adjustments to the provider network in those time periods.
Okay. And I know we're looking at the dollars right here and not the number of services performed or number of hours of case management and those kind of things. So the statistics side of the numbers. So you just mentioned though that, and maybe I misunderstood it, are we delivering roughly the same numbers of services to folks that we serve?
So I don't know that off the top of my head. What I can tell you is that I haven't seen numbers fluctuate that much once you consider the things like the delay in funding and things like that, just the backlog related to the reimbursement mechanisms we're using right now. I wouldn't know specifically. We can certainly find that out if we're looking at roughly the same level of services. Because everything shifted to telemed, I wouldn't expect to see it decrease materially, at least not long term, especially now as things start to open back up. But funding wise, remember, because the way we're funding people is really cost reimbursed, and we're talking primarily about salaries for people here. So that's not going to fluctuate that much. It's really the number of encounters that really has the risk of fluctuating.
Right. And I look at it that way, and I also look at it from the standpoint that we are that we're accruing it, so we're trying to keep it fairly flat month to month for what we pay and how we pay them. Plus, I know you've got some truing up that you do now, almost real time or every month now.
Mm-hmm. Yeah. So because providers primarily are paying staff, those aren't necessarily going, the staff salaries and things like that aren't necessarily going to fluctuate all that much, regardless of let's say a small dip in the amount of services being delivered, because the salary is the salary. Like I said, what could potentially dip would be the number of encounters. But like I said, because a lot of it switched almost immediately over to being telemed allowable, we didn't see any material drops in things other than let's say vocational services or anything in congregate type settings. Those things obviously would drop because COVID had a material impact, but I believe we actually served more people during COVID for case management and maybe therapy off the top of my head. But again, I don't have that in front of me. Certainly we can look into that if you'd like, but that's kind of what we're seeing. The funding doesn't swing all that much.
Right. And our learning curve of how to do the telemedicine is, we're past it. That was last fiscal year. So at this point, we're probably firing in all cylinders on how to do these remotely.
Yeah, I wouldn't speculate on that just because I'm not particularly involved in that, but I suspect that everybody's getting more and more comfortable with it and comfortable using the technology.
All right. Thank you so much. I appreciate it, Anya.
And hey, Anya, before you move on, the expense comparison, we've for the provider network, we're about $7 million less, but that does not negatively affect our provider network. Is that correct?
Correct, because the majority of our providers right now are on cost reimbursed contracts, which essentially means for any cost that they have that's considered an allowable Medicaid expense, we are reimbursing. It's just that we have to do that kind of on the back end,
Right.
Because, to know the exact amount. So because of this whole $2 thing and any of that COVID specific funding has to be reimbursed after the fact. So it just there's a bit of a lag time. So if you think about where we were this time last year, we hadn't quite started the cost reimbursed funding. So this was still back when we were doing normal service model funding for everybody and things were running as normal for January. It's just that there's a delay now because of the way we're reimbursing them kind of retroactively for parts of it. It just takes time to catch up. And then in addition to that, like I said, we do have some adjustments that are going out after, and the seasonality piece of it will come into play. Like some of it just takes time for catch up. You know, December is a heavy holiday month as well as, you know, the new year and things like that. So just sometimes there's a delay related to that.
Yeah, thanks for making that very clear for everybody. I appreciate it.
Yep. Okay, if you went ahead, I think we did this one. Correct me if I'm wrong. Maybe I'm wrong. I can do it again either way. Oh, okay. So then the next list we have is just the top 15 providers that should match the top 15 payments that went out in January. So you can hop, I think it'll be 2 slides over. One more. And that should be it.
Judy, you have a question?
Not about what was presented. It was very clear. Thank you, Anya. I'm still kind of interested in the pilot
Mhm.
for the $15 wage increase. Do you have a timeline for that?
So we have drafted the provider first round criteria. So the goal being to we had talked through kind of what would be, we want a good cross section of providers, a good cross section of individuals being served to try to get a really good sample size. That being said, with a limited amount of money to do this, we have to ask several questions and make sure that we're getting good information. So I believe we've drafted that list. I do not believe that we have sent that out to the providers yet. But the intent will be to push that out to the providers to see who's interested, and then kind of take that and look at, all right, who makes the best sense with the number of individuals they're serving. Are they all from Oakland County? Are they in good financial health in the meantime? Those types of things to make sure we're getting a good sample size and getting a good group to really kind of test, does this theory work? That if we pay people more, the turnover is less and, quality of service is better? Or is that just a theory? So we're kind of in the process of finalizing those details for that first round of survey and request for interest to go out. So I don't think, obviously it's not going to be March now. I know we talked about it potentially being in maybe April that goes out, and then maybe looking at pushing this to the last quarter of the year if we were able to. Again, with just everything COVID related, we don't want to overwhelm them in participating in something like this if this is just more added burden for them, because the reality is the tracking of a lot of this puts extra burden on them. Because there would be, surveys and outcome, areas that we would want to be monitoring and looking at the impact of. So just recognizing all that's going on with the direct care industry right now, we want to be mindful of that.
Okay, thank you.
Say no.
Yeah,
It's a long way to say no. That's how funny.
I've been there before. I understand that. Just what I was kind of curious about is how you were going to solicit interest and who was going to make the final decision. And I know we have some situations where we have people from Oakland and Macomb, in the same environment. So you touched on that. The details will come.
Yeah.
I get that. Thank you.
Yep.
Are there any other questions for Anya before we move on? Seeing none, let's thank Anya for another great presentation. Thank you.
Hi, Eric. This is Sheila. We got 3 new board members on. Can we just get their roll call and location?
Yeah, good idea. Thank you.
Mr. Landsman,
Hi, it's Jonathan. I'm here and I'm in Oakland County, West Bloomfield.
Mr. Torres,
John Paul Torres in Oakland County in Waterford.
Miss Newman,
Melchiah Newman, calling in from Pontiac, Michigan, Oakland County. Thank you.
All right, I think we got everybody.
Great. Thank you for that. We're going to move on to the next item on the agenda is contractual obligations. And Christine Burke is going to talk about our Channel 7 and Channel 4 contracts.
I believe that was from our last meeting.
Yep.
Correct, Sheila?
Yes, there's none noted at this time.
Yeah.
Oh, I guess I printed off the wrong agenda.
Do you see the
okay,
PowerPoint? Eric, do you see the PowerPoint? Because that'll navigate you through then.
Oh, yeah,
quick
not
refresh.
noted at this time. Next, can we go to the next slide? Help me. Okay, we're going to have a quarterly access justice and substance use update. I don't have in front of me who's giving that update. Is that Christina?
Yes, it is. Thank you very
All right,
much.
Christina, take it away.
Okay, great. Good afternoon, everyone. Thank you for having me this afternoon. If you could go ahead and go to the next slide, please. So a quick department overview for you is Access is our largest team of 22 staff, and that's comprised of a manager, a supervisor, referral specialists, and access screeners. Our justice staff is comprised of 12 staff. There are liaisons on that staff, trainers, just a lot of robust services. We have staff in the jail, etc. And then our substance use team comes in at 5 staff. They are movers and shakers, working really hard on a daily basis, as all the teams are, on contract management, technical assistance, etc. Next slide, please. So the 3 initiatives I'm going to talk about today for Access is our continuation of our NCQA accreditation and what we have to do in Access for that, one of the things. And in Justice, I'm going to talk about the Michigan Department of Corrections transition. And in substance use, I'm going to talk about the implementation of our new biopsychosocial assessment tool. I'm a little tongue-tied today. Okay. So starting with Access, we all know that we are NCQA accredited and we want to maintain our accreditation. And so we want to meet those ongoing requirements and maintain the accreditation. And one important piece of that is that we need to answer calls on average in Access within 30 seconds. And we have to have a call abandonment rate that is less than 5%. And so we monitor this through our Access call center. We have a very excellent call center where we can track a lot of data, and this is one of the things. And when do they do this? They do this daily to make sure that we are keeping up with our commitment and really allowing people to access services as quickly as possible. And so not only will we continue accreditation, but we really want to ensure that people served are receiving the highest standard of services. And the completion status, this is ongoing and will be ongoing forever. Next slide, please. So here's just a little snapshot of the data. If you look at the average percentage of abandoned calls, having to wait more than 30 seconds, you see it's extremely low and we are meeting our target. In Q1, it was a little over or close to 4%, and then in Q2 so far, 1.71%. And then the average time, if you see, is that people are well under 30 seconds. In Q1, it was about 15.5 seconds, and in Q2, roughly close to 12 seconds. Next slide, please. And are there any questions about the Access presentation before I move on? Okay, next slide, please. Okay, so many of the board members that were present during the time of this negotiation and the presentations that I did before is that the Michigan Department of Health and Human Services and the Michigan Department of Corrections work together to transition substance use services to the PIHPs and oversight of those substance use services. Formally, they were held within the Michigan Department of Corrections. They received their own funding stream for this. But with the onset of Healthy Michigan, more and more individuals were becoming eligible for Medicaid expansion, and they felt that this was a normal and progressive transition that should happen at this time. And so we did assume those responsibilities. The transition went extremely well. We did establish a liaison position so that person can directly interface with the Michigan Department of Corrections staff, our provider network, and people served to really ensure there's a consistent process. Individuals that are under the supervision of Michigan Department of Corrections are considered a priority population, which means at the time of request, they must be screened within 24 hours regarding what level of care they need. And so April 1st, we were right on board. We actually began accepting referrals in March of 2020 because individuals were being released from residential treatment or from prison, et cetera. And we didn't want the services to delay till April 1st because that was the onset of the contract. We wanted to make sure people were getting into the next level of care and having their needs met. So to give you a snapshot, so far the majority of referrals are to outpatient services, and that's quite consistent with our system outside of working with individuals that are supervised under MDOC. Higher level of care access screenings are about 25% of the time. Our transition is complete. Process improvement will always be ongoing because there's always room for improvement. Next slide, please. And so here you see our referrals and what they look like. It's really similar to our system. They ebb and flow based on people's needs and desires to receive substance use treatment. And this really doesn't look much different. Anya did mention in her presentation, and she's correct, generally in substance use, what I've seen over the last 13 years is that the third and fourth quarters, we tend to have higher admissions. So there is seasonality to that. I completely agree. And I've seen that trend for a very long time. Next slide, please. And with that, does anyone have any questions about the MDOC transition?
Okay, this is Eric. Can you just talk a little bit about the importance of that transition period for people using, so when they're using substances, how important it is to get people or continue people into treatment once they are released from incarceration?
Sure, no problem. It is extremely important. Individuals that are being released from incarceration tend to be at much higher risk of overdose. Oftentimes, if they were entered into the jail and they were using a high level of substances, whether it be alcohol or opiates, etc., once they are released, if they aren't connected to treatment quickly, if they need it, then they could be likely to go back to using the same amount of substances that they used in the past. This is a pattern we've seen, which really their body is not at the same tolerance level as it was pre-incarceration. And so that really can lead a person to a very dangerous situation. So it's just very, very important. Also, studies have shown that if you get someone into services quickly, once released from incarceration, their outcomes are better. And that's just not for their mental health or substance use disorder, but also it decreases recidivism. And so it's important that really you can, to the extent possible, can really plan a person's discharge and connect them to services as immediately as possible once released from jail or prison.
Great, thanks for that. I appreciate you just letting everybody know that. Malkaya has her hand up, and does somebody else have? If Judy, you have your hand up as well, why don't you follow Malkaya? I may have missed you, unless that was from previous. Thanks.
No, I do have another question. That's fine. Thank you.
Thank you, Eric. Thank you, Christina, for the presentation. You might have mentioned this, but I just wanted to ask again for clarity. The contract with MDOC, that's just for people coming out of prisons. That's not at the local level with county jails or city jails?
That is an excellent question, and I did not mention it, so I'm really glad that you brought it up. No, it's anyone who is under the supervision of the Michigan Department of Corrections. We already, individuals involved in the district courts, we've always served individuals at that level, and even there's been individuals over time that were on parole or probation at the felony court level that we've seen. This is just really very focused, and the money was transferred and layered on the Medicaid rates for us to do this. So now we're just seeing a higher prevalence of individuals, but it is individuals that could be on probation, and let's say they had a reoccurrence of substance use, and so their agent refers them. It could be people coming out of prison. It could be someone coming out of jail. It really could apply to all of those scenarios, not just prison.
Thanks, Christina. That's great news. Thank you.
Judy?
Thank you. I just was curious. I'm not entirely familiar with the process. Is the referral process to you when someone comes from the Department of Corrections somewhat similar to discharge planning from hospitals?
I mean, they're two totally different services, but yes, there's a high level of coordination of care. It seems to work the best. And so what we did is we've worked with ongoing, both the parole and the probation agents and their supervisors and district managers on what would work best. So we've provided trainings to the agents and the supervisors. And what we landed on is through the monitoring of our liaison, they load referrals into a smart sheet, so she immediately, gets notified that a referral's occurred, which means then access also is notified, so they can provide the screening within 24 hours. And then she, her name is Michelle Monfortin, our liaison then works with the person to make sure they can get into care, or if an agent says, I haven't heard anything from a provider, she will reach out to the person and say, it seems that you didn't access the services or the referral we gave you. What can we do to help? And so they all just work together. So it is a heavily coordinated process. I don't know if it's not really exactly like when someone is being released from a hospital, but it is heavily coordinated because the population and their priority.
Thank you. That's very helpful.
You're welcome.
That was covered in great detail. I really appreciate that, Christina.
Okay.
Okay, so the next item on my agenda that
I actually just have one more thing, Eric.
Yeah, you do.
Because just the third team. This will be very quick.
Oh, great.
So the new biopsychosocial assessment. So our board members that have been on the board for quite a long period of time know very well about this assessment. We had presented on the GAIN assessment, which is a substance use disorder biopsychosocial assessment, and the high level of criticism from people served and from our provider network that it was an extremely long, it was cumbersome, potentially trauma-inducing. These are just some of the feedback that we received. And so I will say providers from across the state really advocated that this was just not the tool that they felt would be the most effective. The 10 PIHPs also got together and collectively agreed with that decision, and so it has been changed to the American Society of Addiction Medicine, or ASAM, continuum assessment. And this does meet the requirements of the Medicaid 1115 waiver, so we are good with that. Our team is working very, very diligently because this decision was not made that long ago, and everything has to be implemented and in place by October 1st. That is a hard date. There is no delaying that. And so we are working, this is a true team approach, which is really how OCHN functions on most things. And so IT, our utilization management and review, the department, and the ASAM team are working very closely. And of course, PCE, our electronic medical record company, is working with us so we can get that together and have it all set. In addition, the staff member, Brad Sharp, who is really assigned as the lead on this, is working diligently to ensure that people are going to be signed up for trainings, that they're getting refresher ASAM trainings regarding level of care placement in general, and it's going very well. People are working hard. There's certainly no lack of individuals really working very hard at OCHN, I will say that, and this is one example of it because this is a quick timeline and people are boots on the ground making sure it gets done so we can satisfy the requirement. Next slide, please. Okay, and then just funding, really quick. Access is Medicaid and substance use disorders. Justice, the MDOC that I talked about today, is really a Medicaid-driven or a Medicaid expansion, so a Healthy Michigan-driven initiative. And then substance use disorder services are a combination of Medicaid, which is Healthy Michigan Medicaid, and the substance use block grant. All of these are included in the budget in FY21. And I also want to offer any questions about substance use as well, or our funding.
I have just a question. It may sound weird. Is there any way that I could take the two assessments to see like what the difference is?
You know, I will honestly have to ask, because they were not, the gain was not really, they didn't just share the assessments, but Brad probably has it, and he does have the ASAM, so that is a possibility. Let me go back and talk to him and see if we can have it.
I mean, yeah, I can't say it's a high priority, but just for my own research and my own knowledge and understanding, it'd be interesting to take the two assessments and see what the difference is. I mean, if you were getting complaints about the assessment, you know, it's probably pretty, you know, it's probably pretty real. It sounds like of when you say that how people were experiencing the previous assessment. So I'd just be interested.
I think also length was the largest complaint, and the ASAM is shorter as well. But we can take a look at that.
People with substance use disorders have a problem with patience. I can't believe it.
So, and I would also say that really the whole purpose of this statewide assessment is to determine level of care and ensure that the American Society of Addiction Medicine placement criteria is embedded. And so, you know, I think the belief that going straight to the source, since we need to ensure that we are following ASAM requirements, was the better tool to go with, as opposed to a separate tool that just embedded ASAM into it.
No, okay. Okay. Malkai, you still have your hand up. Do you have another question or comment?
Yes, I do. Thank you, Eric.
Great.
Thank you, Christina. That is tremendous news, because there was such pushback at the state level. They swore up and down that they were not going to change that assessment. And I don't think that this is one of those cases where when decisions are made and it doesn't include the people that are directly involved either in the process or affected by the process, this is what you get: confusion, you know, just turmoil, all unnecessary. So I just want to commend the PISPs for being able to pull this off, because I know for personally that the state was just adamant they were not going to change that assessment, no matter how long it took to do it, how often it had to be done. It was just so much about it that just didn't make sense to, you know, tie up people who you don't put barriers in people's way when they're ready for treatment. Make it as short as possible so that they can get on with their lives. And it just seemed like they weren't getting it. So that's great news. Thank you. Good to hear that.
Thank you.
Okay. Any other comments? Are we?
We're good. We're good, Eric.
All right. I really appreciate substance use disorder is obviously close to me, so I really appreciate the update. We're going to move on to under policy management to program compliance, and Dr. Lawson is going to talk about the fiscal year 20 annual plan.
Yes, thank you. Good evening, everybody. I'm really happy to have the opportunity to review all of our accomplishments related to the annual plan in FY20 with everybody tonight. Suzanne, if we can go to the next slide. Just a quick reminder that our annual plan is built around 6 strategic areas. Those were all identified in our strategic plan. And so this slide shows each of those areas and then the number of goals that we had associated with each strategic area. I think there's 2 important notes on this slide, and one is that in each of our in-progress areas that we weren't able to complete in FY20, we can directly attribute that to the pandemic. And then the other note I wanted to make is the one goal that we have under the advocacy and empowerment area that's listed as not started was the goal related to increasing the number of self-determined arrangements for people with mental illness. And that was postponed based on feedback we got from the people we serve, from the board, to Malkaya's point that she just made a moment ago, who said that we really needed to kind of back up for a minute and spend some more time providing education to people about what self-determination is, what it would look like for people with mental illness, and then really start talking to people about what their preference was and focus in on their preferences before moving forward with saying that that was something we were absolutely going to do. So again, this slide gives us a summary of our FY20 review. So we had 51 goals, and of those 51, 33 were completed, and 17 were started and are in process, and then we had the one goal that we did not start. So I think it's important that we note that our team was able to accomplish 65% of our annual plan goals and make progress on 98% of all of our annual plan goals while managing through an unprecedented pandemic last year. I have to admit, I was impressed with us when we compiled this data. So I had to send a huge thank you out to each and every staff person at OCHN. I think the data really speaks to the level of dedication that we have here, and I think it truly is remarkable. If we look at the next slide, the next two slides, I'm sorry, you can move forward again, Suzanne. I covered that. We'll review our accomplishments related to the administration and operation areas of our annual plan. And so we set this up to look at the data in two different ways. So this type of slide will show you what the goal, what strategic area it fell under, and then what our objectives were and whether we completed it or it was in progress or not started for the year. So if we look at the next slide, again, just a slightly different view of the same data. So you can see we had one goal related to accreditation that was completed. We had two goals related to financial reporting. One was completed, one was in progress at the end of FY20. So in summary, if we look at that last total bar right there, we had 8 goals in this area. We completed 5. We had 3 that were in progress. So that gave us about a 65% completion rate in this particular area of administration and overhead. I see there's a question. Do we want to pause?
Is that a question from Malkaya? Oh, Dr. Hans?
Yes, you briefly mentioned the advocacy, the component that is not started. Could you elaborate a little bit on that, and also as to how we are doing it in this current year?
Sure. So the one that we did not start, the goal was specific that we would increase the number of self-determined arrangements specifically for people with mental illness. We have a lot of self-determination arrangements for the people that we support who have intellectual or developmental disabilities. And so that was a goal for FY20. And what happened is after we presented the goal and after it was approved in the plan, we got a lot of feedback from the people that we support who have a mental illness, as well as from our board, that people were still unclear of what self-determination might look like for someone with mental illness. The services and supports tend to look a little bit different. You're looking at helping people to reach an area of recovery so that hopefully they don't require our level of services and supports long term, which can be very different from the way we support people with intellectual and developmental disabilities. And so the feedback we got was, before you start embarking on really pushing to improve the number of self-determined arrangements, that we really needed to take a step back, that we needed to involve the people we support more, and that we needed to do a better job of explaining what that might look like for them, and then understand if that's something that they even wanted us to pursue. And so we did take the step back. We've been working with the providers that we have that support people with mental illness to try and start explaining and exploring self-determined arrangements and what that might look like in that network. And then frankly, the pandemic hit. And so we're still kind of circling back around to that a little bit, but we did start pursuing that in just a different avenue.
Okay, well, it seems like that the pandemic has put us in a pause on this important aspect, because I think self-determination is important for everyone, regardless of their disability or their challenges. So if you could give us maybe in the future, maybe in the next quarter or so, how we are progressing with that. We are almost, I mean, just over a year now into the pandemic. So I think we have to be a little more creative as to how we support people and enable them to, make their own choices and self-determination. Thank you.
Absolutely. Yep. Thank you.
And Malkaya?
Thank you, Eric, and thank you, Nicole. I just wanted to respond to Dr. Uh, uh, to Bajaya's comment. We do need to support people, but when it comes to self-determination within the mental health community, it just wouldn't look the same. And I believe I had even asked for more information to be given to the board, because when you're talking about self-determination, you're talking about hiring your staff, having control over the money that is allocated to you for your services, and having gone through the public mental health system, every time I heard them talking about self-determination, it would just, my brain would go tilt, because I'm like, okay, you're talking about giving me all of the money that I would use to purchase my doctor, my case manager, all this stuff, and then I would have to manage that. And then if I didn't like my case manager, would I fire the case manager and get hire another one within the same organization? It was just so many questions and not enough answers. So that's one of the reasons why personally I'm glad that we backed up on that. I kind of understand some of the desire to want to see more people engaging in self-determination, but I have, me personally, I like to see how it's supposed to work for people who have mental illness, because the way we receive our services are different from the way that people with developmental disabilities do their services, and that's where the confusion, I think, comes in.
Dr. Hans, did you have a point to make?
Yes, thank you, Malkaya, for explaining the differences, but still I feel that self-determination is an important part of empowering people and making them more independent and more involved in their own support system and making decisions. I think that is part of human growth, and I feel it's very important. I would like, that's why I said I like to learn a little bit more about it. Not necessarily any steps that we take we will always be successful. I think sometimes we reach plateaus, sometimes we take step back, but still we have to keep our eyes on the ball as to how we are progressing, how we are dealing with the challenges. And I would like to know something a little more specific about this as to what is the barrier. For example, if a person is not able to decide on how they are or they don't have the tools or skills to manage their budgets or whatever important decisions they have to make, they have to be supported in that and given information, education, training. And I think it's not only true for people that we serve, but also for ourselves. Sometimes we have to use different approaches to things. So I would like to learn a little bit more about that. It's not so much as a criticism or anything about how we are doing things. I know that we are doing a good job. It's just for my own self-awareness about the whole issue. Thank you.
Yep, sure. Thank you. And I think we have some training materials that we put together for our providers, and we can surely share those with you as well.
And Mel kind of wanted to follow up on Dr. Hahn's last question or statement, I think.
I did, and I think, but Jaya, for me, I can't speak for everyone, but just for me, trying to help people reach their goals and live the kind of life that they want to live is self-determination. But does that mean that they have to do it the same way? I guess is the point that I'm trying to make. The way that I've seen self-determination work within the developmental disability community, I can't see a way to translate that easily and effectively over to another population when the system is set up differently. Because you have support coordinators, you don't have case managers that work for the individual core agencies, as opposed to within the behavioral health providers, the case managers that do similar work to the support coordinators are employees. So it's just a different system, which is and then I won't belabor the topic anymore, because it's a lot I don't know about self-determination, but a lot more information needs to be given overall, I believe, and I hope to see that in the near future. Thank you.
I think it's a worthwhile discussion to have. Judy, did you have something to mention?
I would like to, because I'm a strong proponent of self-direction. I sometimes wonder if our language gets in the way. Maybe we should pay a little more attention to that. And additionally, there are many people who are self-directing their services who do in fact have case managers employed by a core provider. So maybe if that can be further explored, that there might be more aspects in common that might appear on the surface. That's all. Thank you.
Okay, thank you, everybody. Suzanne, if we can go to the next slide. So this slide covers our goals and accomplishments in the area of advocacy and empowerment. And so if we look at the next slide, this is our summary data. And so of the 9 total goals, you can see that we've accomplished 4. 4 were in progress, and then the one we just discussed that was not started. So we had about a 44% completion rate in this specific area. And moving into our next area, these were the goals and related objectives for our budget and finance area. And looking at the next slide with the summary data, you see 9 total goals. We completed 5, 4 were in progress. So we had about a 56 completion rate related to the budget and finance area of the plan. And next is our health and wellness section of the plan. And if we take a look at the summary data, then we can see we've got 7 goals, 6 were completed, 1 was in progress. And so we had about an 86% completion rate for health and wellness. And the next is our supports and services area of the plan. It's our largest section of the annual plan. And that's pretty in keeping with tradition. And in the summary slide, you can see we had 14 goals, we completed 12 and had 2 in progress. So we had an 86% completion rate in this area as well. And then last but certainly not least, these are the goals and accomplishments related to technology and innovation. I wanted to note here that what's not reflected in the annual plan progress was the immediate and heavy lift we had to transition over to a virtual world and to function successfully. from telehealth to ensuring our own staff had the equipment that they needed to continue to work remotely. I think we really knocked it out of the park this past year from an IT perspective. And then I also just wanted to note that it was really a lot of forward thinking and innovation we had in previous years that really set us up for success to make this transition seamlessly when we really needed to. So if we look at our summary data, we can see we had 4 total goals, 2 were completed and 2 were in progress. So we had a 50% total completion rate in this area. And so next slide, that just concludes our summary of our accomplishments for the FY20 annual plan. So I can pause and just see if anyone has any additional questions.
Judy, I see that your hand is still up. Did you have another point to make?
I did not. I am sorry. Thank
Oh,
you.
it's okay. Great. Is there anything else for Dr. Lawson? Dr. Hahn? Oh.
Yeah. Only thing is, I'm still I'm a little more confused about self-determination for people with mental challenges. So in the future, if at some point, Nicole, you could present something or give us a brief summary of what self-determination looks like in a perfect world.
Yes, we do have the training materials, Dr. Hans, that are specific to what self-determination would look like for people with intellectual and developmental disabilities, which I know you're familiar with, but then we also have one for what it might look like with someone with mental illness, the similarities and the differences. So we can share those materials with you as well.
Thank you.
Yep.
Jonathan, did you want to add?
I did. It sounds like we do have a new topic to add to our list of topics, either for either the COW meeting that we're having like today, or at a regular board meeting, so that more of the public can understand how does it work on one side, how does it work on the other, plus also touching on things like fiduciary intermediaries and where do guardians play or not play in all that. So something I think we'll take back to the executive committee, and we'll talk about where we can fit that into our calendar. But thank you, Nicole. Very good.
Yeah, I'd certainly be interested in learning a lot more about it as well. I thought that the discussion was good to, just raise a lot of questions that I didn't think about. So thank you.
And the other that I don't know is where all that plays in the substance use world. So, which is, I don't want to say the forgotten group, especially since Christina just did a big presentation on that this evening.
I appreciate that. Great. So let's thank Dr. Lawson for her presentation. We're going to move on to the next agenda item, which is the Sentinel Event Review Committee report. And I think Amy and Wendy are going to make a presentation for us.
Yes, thank you. And good evening, everybody. For those of you who are not familiar with me, I believe we have new board members since I last presented. I'm Amy Heinzelman, and I'm the clinical supervisor, and I'm responsible for the team that participates, the majority of the team that participates at the CERC committee. So Wendy and I will go through and explain our different roles in the process and give the annual report. Wendy, you want to introduce yourself?
Sure. Good afternoon. My name is Wendy Schiller, and I'm the manager of quality improvement.
Okay, thank you. Next slide. So I'm going to start out with an overview of some of the definitions. Much like we use acronyms, our Sentinel Event Review Committee, we have our own language, if you will. And so I'm going to do a brief explanation of definitions and terms, and then we'll get into a couple slides later a little bit more in depth. Our Sentinel Event Review Committee, or CERC as it's fondly known, is the place where we determine if an incident report or an incident that took place in our network is at such a risk level that we would determine it as Sentinel. And I will explain later what Sentinel means, but it basically means that the event, we believe after a thorough review of the record that there might have been opportunities to prevent or change outcomes in what happened in the incident. The incident reports come in 3 different categories: risk events, critical events, immediately reportable events, and then those are determined whether they're Sentinel or not. Each of those reports are reviewed, and we determine if they're Sentinel, and then if they are Sentinel, we issue a root cause analysis to the provider that is providing the direct service to the individual. Next slide. So, whoops, sorry. The folks that make up the Sentinel Event Review Committee are the clinical team, our administrative and special projects coordinator, all of the clinical analysts, and myself and Stephanie Wilson, the clinical director. The director of rights and advocacy also is part of that team. Our medical director, soon to change titles when we get our new chief medical officer, I think it is. I'll have to get used to that one. And then our quality team participates once every month to go through and evaluate the root cause analysis, help us evaluate the root cause analysis and determine help the committee determine whether or not that we accept it. And the quality team is the quality analyst and the manager of quality improvement, Wendy. Next slide, please.
Amy, excuse me for just a second.
Sure.
It looks like Jonathan had, before we get too far in, I just wanted to double check to see if Jonathan had a question.
I do. I have one, because, and you pointed it out that we have a number of new board members since you last presented. You've mentioned Sentinel event. What is a Sentinel event?
So if you will indulge me, we will go through those definitions in more detail as the presentation goes on. But a Sentinel event essentially is when an incident report is written and we review the record and we have cause to have concern about the events and the services leading up to the incident report, either that might have influenced the outcome of the event or might have had a direct cause in the event. And so when we look at those incident reports, we have to look at them with the eye. Is there sort of the questions that we ask ourselves are, is there something the provider could have done differently, could have done more of, that might have prevented the incident itself? So that's kind of the questions that we ask ourselves to determine whether or not an incident is determined Sentinel. Did that help?
No, that sounds like the process. So what I was guessing, but I mean, I know, but it's a Sentinel event is typically something where a death or a serious injury.
Oh, yes, yes. Okay, I gotcha.
That's what I wanted, and you probably do a better job of explaining that's what it is to our board. That's why I thought I'd ask.
Yeah, sorry about that. So typically when an event is determined Sentinel, so we review all the reports, whether they're Sentinel or not is determined after we do the chart review. When it is determined Sentinel, typically it revolves around people who have died suddenly, and less common, but also I'd say probably the second cause that we determine Sentinel most often is people who have been arrested. We have also gotten a lot better at determining the difference between Sentinel and just a clinical concern. So when we're reviewing a record, we see what we see. And when we find things in the record that are of concern, but maybe either not related to the incident report, so we can't determine the event Sentinel, but we find information, we will work with the providers and share our clinical concerns, and they respond to us. We usually ask them to please explain, for instance, I'm trying to think of one that might have been recently. Please explain, or will you please review the chart and help us understand how the acute care discharge protocol was followed. And the incident report was not about an acute care discharge, but there was an acute care discharge in a recent time period, so my staff will have read about that. So the Sentinel part is really when we determine that there is a relationship between what a provider did or didn't do or could have done differently or could have done more of that might have either caused or influenced the fact that this event took place at all. Is that better?
Yes, thank you. I'll let you go on.
All right, thank you. Oh no, I just got a message that my computer's going to restart. Let me get rid of that. I do not want that to happen. Okay, sorry about that. You know, technology is great. Okay, so we are back at, so the Sentinel Event Review Committee, we meet every single week on Thursdays. Part of what we do during that is determine whether each incident report that is brought to the Sentinel Event Review Committee is Sentinel or not. We also then request the root cause analysis, and then again on a monthly basis, we review the root cause analysis that come in from our providers, and we determine whether or not how they wrote the root cause, and Wendy's going to go into more detail about that, whether that's acceptable or not, and whether we think that they've covered all of the requirements in a root cause analysis. Next slide, please. All right, Wendy, I believe that's you.
Okay, thank you, Amy. This bar graph shows you the total volume of incident reports from the last several fiscal years. So let me go back to fiscal year 19 just for a moment for the benefit of those that were not here to be part of that discussion. So we saw a significant increase in fiscal year 19 in the number of IRs. And after consulting with the Recipient Rights Department, a lot of that was really attributed to a lot of increased effort and focus from the Rights Department in that year to really increase communication about the expectations of the incident reporting. So they had added additional trainings, they had increased the ongoing communication at the quarterly provider meetings, as well as the specialists were really reaching out to all the sites in their territory, and they really put a lot of additional effort into that. So we saw a good increase that year. So in fiscal year 20, as you can see, we see a significant decrease again of over 5,500 incident reports reported. So once again, I spoke with the manager of Office of Recipient Rights, Jean Fentner, and really this can also be attributed to a lot of the pandemic closures of vocational sites and some other programs, as well as limited community access that people had during the pandemic time. So we believe that's why we see a decrease in fiscal year 20. Next slide, please. So based on the codes that a member of the Rights Department assigns to the incident report, some incidents are categorized as immediately reportable. So immediately reportable events include those that fall into the categories that you see here on this slide. So we had 14 total of these types of events in fiscal year 20, and the table provides the average number of events per month. So once the event is identified as immediately reportable, notification is sent to MDHHS, and the incident is then assigned to a clinical analyst for review. And they look at it to identify any gaps in service and just to ensure that the services were delivered according to best practices. And each of the incidents are then brought to the CERC for review. So the deaths need to be reported to MDHHS within 48 hours, and any other category you see here within 5 business days. And so when we refer to investigated deaths, these are deaths that occur as a result of suspected staff member action or inaction, or any death that's the subject of a recipient rights, licensing, or police investigation. Next slide, please. This graphic displays the 14 incidents broken down by the type of incident that was reported in each quarter. Next slide.
Wendy,
Oh,
Malkai has a question.
okay, Malkai.
I'm sorry, Wendy, I couldn't get my hand up quick enough, and it's
Okay, I
two
didn't know.
slides back. Well, it has it on this one too. You don't have to go back. Why are you reporting on the average per month? What does that particular data tell you? The average per month on these different events?
Oh, it's just a way of looking at the total number. So when we compare it year to year, we can just see how it fluctuates. So that's why I have it kind of presented both ways. Some people would like to see it this way, and then I also have the number of each per quarter. So it's just a different way of looking at the overall numbers.
Okay. Thank you.
Can move to the next slide again. So risk events are any event that puts an individual at risk of harm. So when an incident is identified as a risk event, based on the code, a quality analyst is assigned to review that incident. So we actually review the majority of risk events at OCHN because many of these are reported by the residential and vocational sites. So the corrective actions really are going to involve the agencies that we have oversight of. So core provider agencies do conduct a review of some of the risk events, but just those that are that take place at the core provider sites. So this graphic displays the average number of, this is the risk events by quarter, and we had 203 reported in fiscal year 20. So last year we had 225 in fiscal year 19, so it's a slight decrease. Next slide, please. So this pie chart just shows the 203 risk events broken down by the incident category for the entire fiscal year. So we can see that, I'm sorry, go back. I have another comment about that. So we can see that hospitalizations is the highest category, and that would include people that have had 2 or more hospitalizations in the previous 12 months due to illness or medical condition. So the average we have is about 10 per month of that type of incident. So we continue to work on healthcare integration and coordination of care efforts to help decrease the medical risks for individuals that we serve. Next slide. So a root cause analysis is required for any incident that's identified as either a risk event or a Sentinel event. So the process really involves a review of the factual events that may have contributed to the incident, and it identifies a causal factor. So based on the outcomes of that investigation, the provider must ensure that there is a plan of action developed and implemented in order to prevent further occurrence of that type of incident. So the plan must identify who's responsible for implementation, as well as how the implementation will be monitored moving forward. So the intent of this process is really not to focus on that single event necessarily, but we really want to identify steps to take for systemic improvement. So Amy already touched on this earlier, but whenever the quality team member would review an incident and identify some sort of clinical concern as part of that review, then that's when they contact a clinical analyst and they go through that clinical review process that she mentioned. Next slide, please. And I will turn it back over to Amy.
Thank you, Wendy. Had to make sure that I was off of mute. So these are the codes, again, that when the incident reports come in, they're assigned a specific code based on the type of incident. And these are the codes that are considered critical. And so my clinical staff reviews every single incident report that is related to what's determined as a critical incident. Again, these numbers present the average per month. And if you want to ask Melkaya, we also will present the actual numbers. This is just another way of presenting the information. The next slide, please. So in fiscal year 20, sorry about that, I had a change in my slides. I have some notes on my own slides. In fiscal year 20, we had a total of 859 critical incidences. And again, based on all of that list of types of events that are considered critical. And this is by quarter in fiscal year 20. This is just the numbers. If you could move forward again. The number of Sentinel events, and again, of all the events that were reviewed and determined Sentinel, this is the number based on the type of event or type of incident report that was determined Sentinel. And again, if you think back to what I said earlier, the numbers that we typically see that we determine Sentinel are mostly related to people who have passed away or arrested. And again, this is for the 12 events that were determined Sentinel in fiscal year 20. 4 were from death and 4 were from arrest. And then the rest were 1 each for hospitalization and investigated death, emergency medical treatment due to an injury, and death by suicide. Next slide, please. So for those of you who were not here in the last couple of years when we presented this report, in particular last year, I did present some of the data that we were working on gathering, and we were working on dashboards at the time. And as we were moving into that, we started in the midst of a pandemic. And so working on those dashboards had to pause for a moment. And then we also moved from dashboards to Power BI. We're back at getting the Power BI reports that we need in order to more successfully and accurately review the data in aggregate. So we'll be able to show, for instance, one of the things that we did when we had a dashboard was anytime a single person had 10 or more incident reports written about them in a 30-day period, my staff would always go in and review that record and see, were these events related to each other? Was there something that we could pick up based on what we were seeing in the record that we might be able to share with the provider so they could do something differently? So we're really looking at how the data that we have, a lot of the data that we get and that goes through the CERC committee is narrative data. So it's been a little bit challenging to take narrative information and put it into a format that would allow itself to be sorted and develop charts and graphs and things like that. But my team and IT, thankfully for IT, can really help us work through those things. So we are in the process of getting that. And so I will say confidently by next year, I will probably be able to give you some snapshots of some of the Power BI reports that we're working on. And our intent is once we get those Power BI reports up and running, my analysts will go through and look at the data. They'll analyze the data and they'll develop reports that will be shared with the CERC committee, so that the CERC can see, again, we're all in the moment when we're on that meeting. And so we don't necessarily get to see the bigger picture or the view over time. And so these reports that we're developing will help us see the bigger picture and the view over time of the type of incidents, the things that are going on that cause concern in our system or cause people to have an incident report written. Next slide, please. So the, is that one yours, Wendy?
No, but I can talk about it if you want.
Sorry, my own PowerPoint seems to have failed me, so I'm not sure between the two of us. Anyway, so the impact for people in reviewing all of the critical incidences and all of the incident reports, the impact of for the individuals served in our network are to look at our clinical best practices being followed, are the clinical protocols that are written and reviewed every single year, are those being followed? We can identify, Wendy had stated earlier, any gaps in the support or services, and we can address those via the root cause analysis process. Oh boy, here goes this had to happen today. Sorry, I just got my notice for restarting my computer just happened again. That's very distracting. So really the reviewing of all of the incident reports is to make sure that we have a good handle on the types of things that are going on in our system that would cause one of our providers to need to write an incident report, so that we can then, from our point of view, look in on the record and talk to our providers to see, is there something that has gone wrong? How can we help? How can we assist in making sure that we have better outcomes for individuals in our system? Next slide, please.
So there are a number of policies and procedures that really guide the CERC through this process. And the main policy that defines the CERC process is Recipient Rights 31.1 Sentinel Event Policy. And this is reviewed and updated annually. We also have a number of written procedures related to risk event reporting, CERC, and root cause analysis that we also update on an ongoing basis. So we also report on all of the activities of the CERC annually in the year-end QAPIP as well. Next slide, please.
Okay, so any financial or funding impact related to the review of incident reports and or the CERC committee really is about our staff time that is devoted to reviewing every single incident report, and then the determination of Sentinel, and then meeting weekly with the CERC committee, which includes the people that I listed earlier. So there's a lot of staff time involved. There may be some of the outcomes that we find when we do some of the analysis that we've been able to do so thus far is we'll start to identify some trends, and trends may lead to looking at providing some network training, because we see trends either across a network or we see trends across the entire service provision line. So if we do see a trend and it does require network training, that would be something that may or may not have a financial cost, certainly would involve more staff time. And then for the overall impact, we really are looking at, again, improving service delivery. It's not a blame or shame. We really look at this as trying to partner with our network to improve service and to make sure that the individuals served in our network have better outcomes. And I believe that's it. Do we have any other questions?
I am not seeing it. Oh, go ahead.
I have a question to Kadas. I apologize. You can't see me. I'm just on by the phone. So first, I want to thank you so much for the report. I mean, it's extremely important, and everything that you do is very, very helpful, you know, and for us to understand. I really wanted to mention, I like the slide, you know, you have 19 slides. So this is 6 of 19, where you talk about the incident report review, and you show fiscal year 16 and 17, 18, 19, and 20. So I think for the board, you know, just as you're presenting, if it's possible, it would be great to also have a comparison of what the, you know, what the incidents were in each year, just because every year is different, but it's in, you know, just like you're going to compare how many incidents we have, you want to know, you know, for
the
your
type
committee,
of incident.
the type of incident. Yeah. And with that matter, I don't know if it's possible, but to even know, because it was such an unusual year, if any of them were COVID related, and you may not even know that, but you know, if you can add that for next year, or even if you even know off the top of your head, I'm just curious, in 2019, even though I sat through and heard that report and probably could look it up, you know, what the comparison was from 2019 to 2020.
So I don't know the comparison. I will say we do know that certainly the number of individuals who died during this last fiscal year, there was a jump related to COVID deaths. And I want to say anecdotally, and I'm pretty confident that none of the events that we determined Sentinel were related to anybody that died from COVID. But I can't give you a comparison. I want to say the types of incidents that we determine Sentinel stays pretty consistent from year to year in those 2 top categories, people who have passed away and people who were arrested. Some years we may have determinations when somebody died by suicide might be slightly higher than what you saw on this presentation, but the numbers, I did look back at some of those numbers, and I've been doing this committee for a number of years now, and nothing like that sticks out in my mind, but we can certainly add that for next year. Absolutely.
That would be great, just to, you know, so we have an understanding. But thank you. You did a very good presentation, and it's, you know, it's very important.
Thank you.
Just to add to that too, there, you know, most of the categories decreased because our number went down significantly. Unfortunately, the category that did increase was, as Amy mentioned, the number of deaths, as well as the hospitalizations due to medical conditions and illness. So it was a significant increase in the number of deaths by about 78 people, and 36 of those were attributed to COVID-19. So I do have that to report.
Yeah, if it was part of this. I think it's important to show, you know, to really have a full understanding, because we've, you know, been through a pandemic too. Thank you.
You're welcome. Any other questions?
Doesn't look like we have any other questions or comments, let's thank Amy and Wendy for the work that they do with the committee. It's obviously important work that we do to improve services. So thanks so much for the presentation.
Thank you.
Thank you.
The next item on the agenda is Vicki, I think, is going to talk about a reappointment on the RRAC committee.
Yes, thank you, Mr. Lindemeyer. So we do have one person that is up for reappointment, and that is Nancy Ristich. The RAC committee did discuss her reappointment at their February meeting, and unanimously we did vote that we would like her to be reappointed. Ms. Ristich will be completing her first 3-year term, so she is eligible to be reappointed to a second 3-year term. Ms. Ristich is a valuable member of the committee. She attends meetings, she participates in discussions, she brings the perspective of as a parent as well as a longtime advocate, and just most recently she was also voted to be the chair of the RAC committee for the next year. So this will need to be an approval item at the board meeting, and so we are asking that Ms. Ristich be reappointed to a second 3-year term. Any questions for me?
Doesn't look like it. No questions for Vicki? Jonathan does. We gotta take her.
Okay. Hey, Vicki. Congratulations on the RRAC being making the recommendation. How many additional spots are still open?
Sure, good question. So we do have 2 spots that will become open. We do have an individual whose terms will be ending in April. So then that will give us 2 spots that are open for either a primary or secondary person served. And then we still do have the member at large spot available. I have thus far received 4 applications for those 2 vacancies. And at the April 1st meeting, the RAC committee will be interviewing those 4 individuals and any other applicants that we get before that time.
All right, thank you.
Thanks for asking.
Okay, thank you, Vicki. Appreciate that. Next item on the agenda is other business. Do we have other business? Not hearing any other business. Let's move to public comment. Do we have any additional public comment?
No, we did not have any public comment this evening.
Okay. So what's next on our agenda? Board comments. Do we want to go through a roll call and just call the board members and ask them if they have comments?
Sure. Mr. Furman.
I just want to say thank you very much for all the very informative presentations tonight, and thank you very much for the staff time and talent in putting them together. They were all very worthwhile and very enlightening tonight, and just a reminder for everyone to stay safe. Take care and have a great week.
Ms. Bernard.
I want to thank everybody for being here in the meeting. I particularly want to make a comment about our discussion regarding the mental health and self-determination. I thought that was a really worthwhile discussion, and really look forward to having further discussions and learning more about the ideas that OCHN has for self-determination for people with mental health in the mental health situation. So anyway, thank you, everybody. Enjoy the beautiful weather this week.
Dr. Todd.
Hi. Somebody mentioned how we've really increased our skills in the technological online administration of services. I think it's almost miraculous what our awesome staff has actually accomplished without a hitch. It's just unbelievable that we could pull it off like that. On the other hand, I'm looking forward to not having Zoom meetings and meeting with all you people in person. That's all I have.
Dr. Hans?
Another great meeting. Learned a lot, especially about self-determination and challenges faced by people. Thank you for all the presentations, and I wish everyone a nice evening. Be safe and stay healthy. Thank you.
Miss Newman?
Thank you, Sheila. Thank you to the staff for providing the information you brought to us today. I like the formats that you've been presenting in. You followed the template that was given, so it makes it easier to understand the information, the impact that it has on the budget, the people we serve. So I really appreciate that. But I also have a question for Mr. Landsman. You had mentioned that there's a list of topics that is under consideration with the executive board. Will that be shared with the rest of the board?
Well, I will inject right now, if you don't mind, Eric. We do have a list. It is basically the list that has been gathered from all of our prior years of other meetings from when Judy was our board chair. We can share that at the next. We could share that at in our boardable. Absolutely.
Thank you.
Mr. Torres?
Oh, I'm here. No comments from me. Thank you.
Miss Summers?
Thank you. Thanks to everybody who put together these very informative presentations. I always continue to learn, even when I think I know a little bit more than maybe I do. But what I would like to add is I do hope that there will be further exploration regarding self-determination or self-directed supports, however you want to phrase it. For all we serve, I've been a student of this topic for 21 years, and I still learn. This is not a new idea, it's an ever-evolving idea, and I do hope that any future presentations will include people that we support and serve. There are people with mental health issues and developmental disabilities who are firm believers in this, and I think it might really help flesh out the topic a bit. And other than that, yeah, enjoy the weather and take care. Thank you.
Miss Root? Miss Root, I think your mic is still on, or you're mute. Mr. Landsman?
Good evening. I just wanted to say thank you to everyone who put in the time to prepare their presentations and present to us. It was very informative, from the budget to the Sentinel events and our annual report from last fiscal year. So thank you to all of you, and I echo all of the sentiments from the board members before me, Hadas, Adam, etc. So thank you.
Mr. Lindemeer?
Hi, I'd just like to recognize all of the staff and the presentations that they made, understanding the incredible challenges that they've all had during COVID over the past year, and the fact that we continue to do the work, or that they continue to do the work, is remarkable. And the progress that we've had on our annual goals, it's great to see, understanding that we're limited because of the virus. I just really appreciate the continued excellent work of all the staff of OCHN employees. Thank you. And with that, unless there is anything else, we will stand adjourned.
Thank you.
Thank you.
Good night.